Hello and welcome everyone. Good afternoon. I'm Swikriti Baskoda. I'm currently the Vice Chair of ASC e-Journal Committee, and today we are back with our e-journal presentation. The title of our journal talk is The Cytomorphology of Renal Angiomyolipoma. We have our presenter. Let me introduce our presenter to you. He is Dr. Amer. He's currently a second year pathology resident at Geisinger Health System, and he's also the chief resident. He's also the CEP resident Fulham delegate and US CAP ambassador from Geisinger Health System. He's interested in cytopathology. That's why he opted to do this. We're so grateful for him doing this. Welcome, Dr. Swid, and take it over.
Thank you, Dr. Baskora, for the introduction, and it's my pleasure to be here today for presenting the topic of cytomorphology of renal angiomyolipoma, the performance and the accuracy of touch preparation of core needle biopsy. And before and foremost, I would like to thank the organizers for giving me the opportunity to present this topic. So let's start it. So this is my Twitter account. So if you guys wants to follow me, and as Dr. Baskora presented me, I'm a second year and chief resident physician at Geisinger Medical Center. And as well as I'm a Geisinger CAP resident form delegate and US CAP ambassador. So before I begin, I would like to acknowledge the contributions of the authors of the research paper I'm presenting today. And this study was conducted by Dr. Gelarden. He's a cytopathologist fellow in Northwestern University. Dr. Alcino Gama, he's a resident in Northwestern University. And Dr. Choy, she's the assistant professor, associate program director of the pathology residency and cytopathology fellowship, as well as the director of the FNA service in the Northwestern University. And whose dedicated efforts and expertise have made this research possible, and I'm honored to present and share their work with you all. So the objectives of today's presentations are centered around the utility and the diagnostic value of touch preparations obtained during rows of core needle biopsy for the diagnosis of renal angiomyolipoma. And the study aims to evaluate the cytologic features of touch prep of core needle biopsy in the evaluation of renal angiomyolipoma, as well as assess the cytologic features of the touch prep, and as well as identify potential pitfalls that one should be aware in the diagnostic process. As we dive into the findings of the studies, it is crucial to understand the significance of accurate diagnosis and the characterization of renal angiomyolipoma. And by utilizing the touch preparations obtained during rows of core needle biopsies, we have an opportunity to enhance our diagnostic capabilities and provide more precise and timely patient management. And throughout these presentations, we will explore the various cytologic features observed in touch prep of core needle biopsies and discuss their relevance in the evaluation of renal angiomyolipoma. So the introduction of this paper highlights the several important aspects of renal angiomyolipoma that sets the stage for our discussion today. And so angiomyolipoma is the perivascular epithelioid cell family tumor. It's a mesenchymal neoplasm that characterized by various amounts of blood vessels, smooth muscles, and adipose tissue. It can occur sporadically or in the context of tuberous sclerosis complex. And the angiomyolipoma is usually so-called or exhibit as myomelanocytic immunophenotype with co-expression of the proteins such as SMA, desmin, as well as melanocytic markers that includes HMB45, melan A, and others such as MART1. So these solitary, well-circumscribed masses in the kidneys present unique diagnostic challenges. And with the increasing utilization of the pericutaneous core needle biopsies to evaluate renal masses, the need for adequate material for the diagnosis and ancillary testing becomes crucial and more important. And this is where like ROSE or rapid on-site evaluation using touch preparations of core needle biopsy plays a significant role in our practice to ensure the procurement like of the sufficient material and allowing for also timely specimen triage. While angiomyolipoma is a lesion that usually reliably be diagnosed by radiologists and images, sometimes the confirmation of tissue diagnosis may be needed, especially in the equivocal cases. So, however, the diagnosis of renal angiomyolipoma by cytopathology remains a little bit challenging with limited reports in the English literature. It is worth noting that previous published cases were primarily evaluated by FNA only, without the incorporation of the touch preparations of core needle biopsies. And these cases ultimately required confirmations from different aspects such as histology, cell block, H&E staining, as well as other IHC markers that we use. And the combination of cytopathology and clinical and radiology support as well. So given this backdrop, the objectives of the studies basically will aim to address these limitations and enhance our standings of the cytologic features and diagnostic performance of touch preparations. So regarding the material and methods, the methodologies that employed in these studies provides the readers and us with a comprehensive approach to investigate the utility and diagnostic performance of touch preparations obtained during rows or of the percutaneous core needle biopsies. The study adopted a retrospective approach and involving a thorough search of the pathology database at Northwestern Institution. The search encompassed like core needle biopsy specimens of the kidney masses collected between 2000 and 2021, specifically targeting the cases that underwent rows using touch prep of core needle biopsy and were either suspected or confirmed to be angiomyolipoma based on the preliminary or the first reading impressions or the subsequent resection final diagnosis. And to perform like the core needle biopsy, the interventional radiologist employed using a CT scan or ultrasound image guidance, which ensures the accuracy and the precise sampling of the kidney masses before like giving it to us as cytopathologists and get a chance to look at the slides. Subsequently, the touch prep slide were prepared from each core needle biopsies, air dried and stained with the modified Gamesa DevQuick for rows evaluation. The evaluation then got conducted by a board certified cytopathologist who assessed the adequacy of the specimen and provided the on-site impressions when necessary. Following the ROSE procedure, the core needle biopsy specimen were placed in formalin and embedded for histologic evaluations. Then the histology sections of the core needle were end up stained with H&E, allowing for detailed examinations. And additionally, IHC was performed using appropriate positive and negative controls. The key antibodies that utilized in the IHC analysis to diagnose angiomyolipoma includes those that against melon A, HMB45 antigens, as well as SMA and desmin. The research team meticulously reviewed patients' demographics, clinical informations, and imaging findings for each case, ensuring the comprehensive understanding of the context surrounding the renal angiomyolipoma diagnosis. Then relevant data pertaining to specimen adequacy, on-site impressions, cytomorphology features, histological features, and IHC results were gathered from pathology reports. In the instances where available, also glass slides were obtained for review and gut analysis. And so it is also important to note that the ethical considerations were upheld throughout the study, as this research paper got approved from the Northwestern University Institutional Review Board, and to ensure the protection of the patient's rights and the privacy. So the study included a total of 24 cases from 24 different patients, with 20 cases mostly were from females being confirmed as angiomyolipoma at the final diagnosis. And only one case was excluded because the FNA only was performed without the touch prep. The median age of the most patients were around 60s, 65 years. And it is worth noting that the angiomyolipoma was 90% of the cases was diagnosed incidentally, either asymptomatic, the patient didn't have any symptoms, or with symptoms unrelated to the renal mass. Some of them such as like chest pain, hematuria, diarrhea. So the radiologic information provided at the time of the biopsy revealed that the confirmed angiomyolipoma cases has a median size with 2.1 centimeter, which ranges from 1 to the 15 centimeter. And interestingly, like only 2 cases were exceeded 10 centimeter in size, which highlights the prevalence of smaller angiomyolipoma lesion in this cohort. Regarding the radiologic impressions, it was available in 19 cases, and among these cases, angiomyolipoma was considered as a differential diagnosis in around 60% in 11 cases, and indicate that was in the list of potential diagnosis based on radiologic findings. However, the angiomyolipoma was favored as without consideration of like other malignancies in only 2 cases. And in the remaining 17 cases, the differential considered 1 or more malignant processes such as renal cell carcinoma, liposarcoma, or metastatic carcinoma. So this is a schedule that in the paper that shows the clinical, pathologic, and imaging characteristics of the 20 confirmed angiomyolipoma that are summarized in the table that's shared by the authors. And you can see like here and that most of the patients were from were like female, and the age were like around in the 60 range. Then if you look at the presentation, most of them has like asymptomatic or like different kinds of symptoms that unrelated to the actual mass, such as like chest pain. Only one has flank pain and the other is abdominal pain, diarrhea. And if you look at the imaging impressions, you can see that only 2 two of the cases has got like impressed as angiomyolipoma, and one of them had I think number 11 um, had the history of tuberous sclerosis. So the study also highlighted the adequacy of on-site evaluation during Rose procedures, and out of like the 20 confirmed angiomyolipoma cases, only like around 60 or 80% of the cases were considered adequate for diagnosis with the on-site impression available. Interestingly, 4 cases were deemed inadequate with documented on-site impression ranging from either scan cellularity to non-neoplastic adipose tissue or normal renal parenchyma. The evaluation of glass slides and or pathology reports reveal the presence of major angiomyolipoma components in the cases that got looked under microscope, and such as adipose tissue, spindle cells, blood vessels as well. So here, this is an on-site evaluation was performed in all 20 confirmed angiomyolipoma cases, and all of the cases were in the Rose adequacy was adequate, only with like 4 cases were inadequate, and the Rose impressions were either non-applicable or malignant. There was like around 4 that got impressed as angiomyolipoma. And you can see also the IHC markers that they used it as well. Melan A is mostly there, HMB45, and then a couple of myoid markers. And they also talked about like what components they saw, like such as spindle cells, adipose tissue, or vessels. Here, this is the image that's sometimes as we earlier said, that angiomyolipoma may mimic other neoplasm, especially on the touch prep or during Rose. And you can see here in the figures A to C, you can see this as a case that interpreted as oncocytic neoplasms. And in figure A, you can see the touch prep basically shows numerous cells with abundant eosinophilic cytoplasm around nucleus. And B, the H&E section showed the numerous proximal tubule with occasional fragments of angiomyolipoma in part C, where you see like these fat cells there. And the other figures that showed from D to F is basically another case that got interpreted as dedifferentiated liposarcoma, that in part D that you see the fat cells with either ovoid to spindle cells. But the H&E or cell blocks in the E and F revealed abundant fat components in angiomyolipoma in part E and part F. You can see these spindle cells. So interestingly, 4 cases, as we said earlier, got diagnosed or deemed as inadequate, with documented on-site impression ranging from the scan cellularity to non-neoplastic adipose tissue or normal renal parenchyma. And the evaluation of the glass slides and Amer pathology report reveals the presence of major angiomyolipoma component presents. In the case reviewed, spindle and epithelial cells were observed in all cases, in 100% were all seen spindle epithelioid cells, while adipose tissue were presented in 70% and blood vessels were in 15%. 3 cases only showed 3 components, the spindle, adipose tissue, and blood vessels. 11 showed 2 components, and 6 cases showed only 1 component. And that showed us like blood vessels are basically rarely seen in cases of angiomyolipoma during ROSE. This is a figure that this is A and B is basically a cytomorphology of the renal angiomyolipoma on touch prep of core needle biopsies stained with DEFQuick. The part A is the red arrow is basically pointing the bland spindle to epithelioid cells with eosinophilic cytoplasm with regular nuclei, and part B is basically these fat droplets are basically often seen in the backgrounds, but the individual adipocytes with lipid vacuoles and small eccentric nuclei may be seen with tissue fragments as well. That's the blue arrow in part B. Yeah, my mouse is not working to show it. I don't know why. So additionally, nuclear pseudo-inclusions were easily identifiable in 85% of the reviewed cases, and adding to these diagnostic feature of angiomyolipoma that we discussed. The immunostains performed on the core needle biopsies and or surgical resection specimen demonstrated positive staining for markers such as melan A, HMB45, SMA, Desmin, and that's the support the diagnosis of angiomyolipoma. And the mostly used markers in the papers they said was melan A. The median follow-up time was 47 months for 19 of the 20 patients with confirmed angiomyolipoma. So here, this is a picture of the 11 cases of renal angiomyolipoma that shows nuclear pseudo-inclusion on touch prep, as well as the H&E on of the core needle biopsies. So on the left sides, these are all touch prep, and then the right sides are the H&E slides, and you can see these pseudo-inclusions that has the stains basically nucleus that demonstrate sharply demarcated margins and has the quality matching that of the cytoplasm. Among the cases that underwent subsequent resections, that majority confirmed the initial core needle biopsy diagnosis of angiomyolipoma. However, only one case initially misdiagnosed as well-differentiated liposarcoma that was later revealed, or when they looked at the core needle biopsies under microscope on the H&E, it was turned out to be a fat predominant angiomyolipoma that got confirmed also by the IHCs. So this is a case that misdiagnosed on core needle biopsy as well differentiated liposarcoma, but the final diagnosis based on the resection got revealed as fat predominant angiomyolipoma. And in figure A, you can see the touch prep basically shows these cells with round to ovoid nuclei with cytoplasmic vacuoles of varying sizes, and that's the black arrow that pointing at. And the part B is basically the H&E section of part A, and basically shows these predominantly mature appearing adipocyte in lobule that are separated by this thin septation. And then within the septation, you can see some cells show the small vacuoles resembling lipoblasts, and these are the red arrow on the lower corner of the figure B. And then the other cells, that's the blue arrow, basically shows these numerous vacuoles causing the indentation of the centrally located nuclei that are the reminiscent of the lipoblasts. So 3 cases out of 23 studied cases were not confirmed as angiomyolipoma at the final diagnosis. And these cases were initially suspected to be angiomyolipoma during on-site evaluations, but different core needle biopsies, final diagnoses were rendered, and including 2 cases where clear cell papillary renal cell tumor, and then 1 case got eventually diagnosed as clear cell renal cell carcinoma. So in this figures, it shows the renal cell tumor or carcinoma that mimics the angiomyolipoma and the touch prep. And the figure A, you can see this one case that was called angiomyolipoma at rows that shows very few tissue fragments with suboptimal staining with few bland appearing ovoid to spindle cells without the distinctly clear cytoplasm seen. And this is the black arrow that pointing at these bland to ovoid to spindle cells. But on the subsequent H&E that got from that touch prep revealed these characteristic features of the clear cell papillary renal cell tumor that it's a classic piano key nuclei. That's what is the pink arrow pointing at in figure B. And then another case that was called angiomyolipoma as well at the rows showed similar touch prep findings with few clusters of spindled and cells without clear cytoplasms. And then when the H&E came for that subsequent touch prep showed classic the clear cell renal cell tumor with low grade neoplastic cells. So the discussion section of the paper highlights several crucial aspects of renal angiomyolipoma and its diagnostic challenges. And the authors basically emphasize the importance of preoperative imaging and pathologic evaluations in determining the clinical management of renal masses, especially in considering that a significant proportion of solid renal masses are benign. So while angiomyolipoma can demonstrate characteristic radiologic findings, further evaluation with tissue sampling is often necessary, particularly in the cases that we're not sure or equivocal cases. The presence of angiomyolipoma with scant fat or low fat predominant basically poses a diagnostic challenge for us as or as a pathologist or cytopathologist because they lack the adipose component that can lead to potential sometimes misinterpretation to other malignant neoplasms such as renal cell carcinoma or other entities in the differential diagnosis. The morphologic diversity of angiomyolipoma adds also to the difficulty in recognizing this entity. And we have has wide morphologic ranges such as angiomyolipoma with epithelial cyst or oncocytoma like angiomyolipoma or epithelioid angiomyolipoma. So previous studies evaluating the cytomorphology of renal angiomyolipoma basically primarily consisted of a case report and small case series that highlights the limited available evidence in this area. And these studies basically done only FNA for evaluation and with subsequent confirmation with histology, IHC, cell block, or combination of these methods along with the radiologic or clinical support. So this is a radiology impression was given in 80% of the cases. And you can see in the imaging impression in all these studies, basically giving either indeterminate or giving angiomyolipoma or renal cell tumor. And then they you can see the numbers of like the spindle cells that has been seen on these cases. Has all of them has like these spindle epithelioid cells. However, adipose and vessels where these are the variable components. So the author also emphasized that while radiological impressions of sample angiomyolipoma in this study were consistent with those reported in the previous the previous literature, a subset of cases will still require tissue confirmation despite being favored as angiomyolipoma without consideration of the malignancy. This suggests that some cases with imaging findings indicative angiomyolipoma may still be necessary for a tissue diagnosis due to the clinical uncertainties or the presence of other differential diagnoses, such as renal cell tumor and others. Among the differential diagnoses considered for angiomyolipoma, renal cell carcinoma considered one of the most frequently evaluated, likely because it has these high incidence among other renal tumors. Second one is liposarcoma is also considered due to shared feature with angiomyolipoma as the retroperitoneal locations and the presence of the fat cells. The high frequency of the indeterminate radiological features that got discussed here in these research cases and the inclusion of these malignant neoplasm in the differential diagnosis cases underscore the importance of pathologic evaluation for definitive characterization before making further clinical decisions. And in cases where malignancy is suspected or cannot be excluded based on imaging, the percutaneous renal mass biopsy is an appropriate area for further evaluation. The paper also highlights the increased utilization of percutaneous biopsies for evaluating renal masses and emphasizing its safety and effective method as a diagnostic tool. The on-site evaluation of renal cell mass biopsies using FNA or touch prep of core needle biopsy plays a vital role in determining specimen adequacy and facilitating triage decisions for ancillary testings. While both FNA and touch prep of core needle biopsies have demonstrated high diagnostic accuracy, ranging from 85 to 95%. Their efficacy depends on the experience of both the radiologist as well as the pathologist that's reading or giving their impressions. In some cases, the FNA and core needle biopsies methods are used complementary, and a few studies have shown that the combination of both methods can outperform the FNA or core needle biopsies alone. However, like only limited research specifically basically discussing the use of on-site evaluations that include the cytologic preparations for the workup for the renal angiomyolipoma. Existing publication lack the specific information on site adequacy, diagnostic impressions, or triage decisions. And this studies basically fills this gap by providing insights on the adequacy and diagnostic performance of touch prep of core needle biopsy when we're trying to diagnose angiomyolipoma. So during this study also, most confirmed cases of angiomyolipoma were deemed adequate during rapid on-site evaluation, and all were ultimately found to be satisfactory based on the core needle biopsy analysis. The procedure termination reasons were that include such as bleeding, difficult visualization, and multiple passes interpreted as unyielding of diagnostic material. The low cellularity or presence of adipose tissue and normal renal cells represent a possible pitfall leading to erroneous interpretation of inadequate diagnostic material at TROS. The sensitivity of the preliminary impressions during ROSE on these touch preps was found to be around 44% in this study, and compared to the 71% reported in the literature for FNA alone. The potential difference in diagnostic performance between the touch prep and the FNA may be attributed maybe to the nature of on-site evaluation, which may not allow for thorough review of cytology material and available, as well as available the other information such as clinical and radiologic informations. And moreover, the pathologist deferral in providing a specific diagnostic impressions until core needle biopsies material is available likely contributes to these possible differences observed between the touch prep and the FNA. Notably, some cases favor angiomyolipoma during rapid on-site evaluation, basically consistently exhibited at least 2 of the 3 major neoplastic components of angiolipoma, including spindle, cells, adipose tissue, and vessels. And these observations support the idea that the presence of multiple major components aids in the diagnosis of this entity. Overall, the frequency of identification of major component of angiomyolipoma was similar to previous publications. There was no difference. Spindle cells were the most common, followed by adipose tissue, and then vessels were rarely seen in this study and represent the least identified component in the literature. Vessels are structurally sometimes hard to see during touch prep, and in addition to the presence or absence of angiomyolipoma component, usually other cytomorphology features have been reported that may be seen on cytology preparation at ROSE. And significant cytology atypia, mitosis, prominent nuclei, and multinucleated giant cells have also been reported seen in these entities. At most, description of angiomyolipoma cytology preparation are focused on the major angiomyolipoma component. There's also intranuclear pseudo-inclusions that was been earlier discussed, maybe also underreported in these entities. And while intranuclear, these pseudo-inclusion are not entirely specific and may be seen in other tumors, their findings or presence should alert the pathologist to the diagnostic possibility of angiomyolipoma. And one of these was favored to represent dedifferentiated liposarcoma at TROS. Spindle cell and adipose tissue were seen on touch prep, demonstrating the misdiagnosis of dedifferentiated liposarcoma as potential diagnostic pitfall, and especially considering the liposarcoma is commonly included in the radiologic differential diagnosis with angiomyolipoma. And that's why we use other IHC and other studies that help us differentiate between these entities. Conversely to angiomyolipoma mimicking other entities can also mimic angiomyolipoma, especially based on cytology preparations alone. 3 cases that were favored to be angiomyolipoma at ROSE had different final diagnoses. The scant cellularity with low-grade nuclei and absence of prominent clear cell morphology can be a pitfall in diagnosing clear cell papillary renal cell tumor and clear cell renal cell tumor. All 20 cases were ultimately deemed satisfactory for the final diagnosis based on core needle biopsy. And this is compared to the study that done by Dr. Zhu, which reported up to 6% of angiomyolipoma FNA final diagnosis as non-diagnostic. IHC was used to confirm core needle finder diagnosis in all cases except for one initially misdiagnosed as liposarcoma. Melan A, HMB45 were the most used melanocytic markers, while SMA was the most used myeloid markers in this study. And the use of IHC is helpful to confirm the correct diagnosis, especially after having it as a differential. 4 cases in the study were favored angiomyolipoma based on cytomorphology alone without ancillary studies, but with the use of IHC on core needle biopsy material, 19 out of 20 cases were correctly diagnosed as angiomyolipoma. The utility of the IHC in the study can be compared to cases published in the literature where cytology diagnosis was rendered without the use of ancillary studies, such as IHC in 62 cases. Of these, 44 were correctly diagnosed as angiomyolipoma and 11 were favored to be a malignant. While the small number of cases in this study, single center retrospective analysis and verification bias are potential limitations, and their findings highlight the utility of touch prep in the ultimately assuring diagnostic material for histology and IHC at the time of biopsy. This would presumably reduce misdiagnosis based on cytomorphology alone and minimize the unnecessary surgeries or other invasive procedures. So in conclusion, the findings of this paper shed lights on the effectiveness of the rapid on-site evaluations using touch preparations of the percutaneous core needle biopsies and providing adequate material for the diagnosis of renal angiomyolipoma. The conclusion of the study also holds the valuable implication for clinical practice and patient management, as well as the presence of the spindle, epithelioid cells, and adipose tissue as the most common components observed on touch prep slides confirm the characteristics histological feature of angiomyolipoma. However, blood vessels are rarely seen. Notably, the identification of intranuclear pseudo-inclusion in most cases provides a useful diagnostic clue. Useful diagnostic clue during the evaluation of touch prep or fine needle aspirations. And correlation with the core biopsies and utilization of IHC are crucial for making the correct renal angiomyolipoma. However, this study also highlights the challenges associated with recognizing angiomyolipoma during Ross procedures. Some cases may be prone to be over-interpretations that leads to a potential misdiagnosis as either malignant or non-neoplastic lesions. Therefore, the authors emphasize the critical importance of these other ancillary studies. And as I conclude my presentation, I would like to try to express my appreciation to again to the authors for their work to the field cytomorphology through the studies and their meticulous investigations that has cleared the utility of touch preparations of core needle biopsies in diagnosis or diagnosing renal angiomyolipoma, and highlights the importance of these multiple diagnostic modalities for accurate characterization. And with that, thank you all for your attention, and we are now open for questions or discussions that you may have on this topic for the authors. Thank you.
Thank you, Dr. Swid. Thank you, Dr. Swid. It was a really nice presentation, and thank you, Dr. Gama, for being here and representing the author panel. This is a very rare lead entity, and we do not encounter it frequently. So the publication like these highlights the rare entities, cytomorphological features, diagnostic challenges are really helpful. I'm really grateful for attending this presentation. I learned a lot. I have a quick question for Dr. Gama. In your patient cohort, did you report that whether these lesions were fat poor or they had abundance of fat in your diagnosis, or the diagnostic comments is they have a different prognosis?
So the thing is that my impression from the study is that the majority of the corneal biopsies for AML or for suspected AML, we are biased because they are either challenging cases that were not diagnosed on the radiology, because the majority of them, if there's an inadequate proportion of fat and versus the spinal component and vessel component, normally the investigation stops in the radiology. So everything else that comes to us is normally challenging. So a good proportion of cases, they were indeed fat poor, and that wasn't the differential. Or other cases, we also had some patients that had other neoplasms that was a concern for malignancy, even though the radiology was favoring AML in the differential, but the patient had other issues in the context, so it wasn't appropriate to have a histology diagnosis. So I think these were the two major scenarios, and by coincidence, these are also the two major potential pitfalls for the diagnosis of this entity.
Right. Thank you so much, Dr. Gama. I do not see any questions posted in our question box or the chat box. If you have anything, there's still some time to post it. Feel free to ask any questions to the author or Dr. Swid as well. I'll give it a minute or two. And in the meantime, I'll say that I have encountered only 2 cases in my limited clinical practice so far of angiomyolipoma. Both of them had adipocyte predominance, which made it easier to diagnose with core biopsy. Both of them were core needle biopsy. And actually, one was in the resection specimen done for another procedure. But anyway, this is really helpful. And like I mentioned earlier, I learned a lot. I do not see any questions posted till now, so I would like to thank Dr. Gama again for being here and Dr. Swid for a brilliant presentation done. We will see you all next month for our monthly eJournal presentation. Don't forget to tune in for the Twitter chat the night before the live presentation. Thank you so much. Have a good rest of your day.
Thank you, Dr. Bascota. Thank you so much for the opportunity. This is the first time that I participate as an author in a journal club, and it's been an interesting experience. Thank you so much for the invite, for the opportunity. And Dr. Swid, congratulations. I think you highlighted everything. It's good being on the other side for the first time and seeing that the message was adequately delivered, because you summarized literally everything that we tried to pass along the message to the reader. So thank you so much, and congratulations for this outstanding presentation.
Thank you
so much. Thank you.
See you. Bye.
See you. Bye-bye.
Bye.